we should move to the second speaker, which is James Januzzi. He's going to talk on the prognostic role of ST2 value.
Very well. Buongiorno a tutti, Madam Chairman. Thank you. Before I begin, I just want to thank Professor Di Somma for the invitation. This meeting is incredible. It's longer than the European Society of Cardiology meeting, so I hope you have a vacation planned after everything is completed. It's quite fantastic. And so what I'd like to do today is speak about the use of ST2, in particular, consistent with the GREAT meeting, focusing on its use in patients with acute heart disease. My disclosures are here. Important to recognize I do a fair amount of clinical research, but there are many who probably don't know the most important disclosure I have, which is that I actually was married here in Rome 18 anni fa. I was very young back then. My wife has not changed at all. She looks exactly the same. So for me, this is a particular pleasure to come back to Rome to see my family and spend some time. So I'm going to be speaking today about the use of ST2 for evaluation of patients with acutely decompensated heart failure. As you all know, this is an increasingly common diagnosis, and in patients who are affected by heart failure, there's a substantial risk for morbidity and mortality. Indeed, in the United States, hospitalization for acutely decompensated heart failure is associated with as much as a 25% 30-day rehospitalization rate and a similar 30% risk for death by 1 year. And so tools to better assess the risk in patients with heart failure to adjust their therapies specifically based on the level of risk are needed. And that's, of course, where biomarkers in heart disease have become much more widely focused upon. And from a single drop of blood, we can identify literally dozens of possible biomarkers that we can look at to help make decisions about the presence of disease, the severity of disease, and perhaps guide its treatment. But the problem, of course, is that this leads to a lot of confusion. There are many different biomarkers that are available currently, and it leads us to a great degree of uncertainty as to which biomarkers might be of use and which ones are more interesting but less clinically useful. So approximately 1 year ago, a colleague and I wrote a position paper in clinical chemistry determining or defining, in our view, what makes a biomarker clinically useful. And we noted that novel biomarkers should be easy to measure and interpret. They should primarily reflect important processes involved in presence and progression of heart failure. They should add information about the diagnosis beyond which is already known and be independent to and additive to other biomarkers, and should also be useful for monitoring and treating patients. And while many biomarkers meet some of these different criteria, very few, besides the natriuretic peptides, have reached the level of matching each of all of these different recommended points. ST2 is an interesting biomarker. You've already heard the biology of ST2. It is involved in the development of hypertrophy and fibrosis in multiple tissues, but in the heart in particular, such that abnormal ST2 biology is associated with remodeling and heart failure in animal models. And indeed, if you look in patients with acutely decompensated heart failure, concentrations of ST2 are significantly associated not only with natriuretic peptides, but also multiple cardiovascular abnormalities that identify a patient with a more decompensated hemodynamic profile and a more remodeled and abnormal left ventricle. So this is an example of where the biomarker in humans provides information that you would expect based on the basic science data from animal models. ST2 concentrations are associated with worsening symptom severity in heart failure, such that patients with mild, moderate, and severe heart failure have higher values. And as you already saw, early studies with ST2 demonstrated an essentially linear association between concentrations of ST2 and the risk for mortality at 1 year in patients with acutely decompensated heart failure. We have had the occasion to now follow patients for a much longer period of time. We've been working with ST2 now for close to 10 years in one form or another. Our first paper published was in 2005. And when we look at the longer-term outcomes associated with a single measurement of ST2 in patients with acute heart failure, we can see that the prognostic associations last out for a considerable period of time after presentation. Now, there are some certain important subgroups of patients with heart failure. I'll remind you that literally 50% of patients presenting with decompensated heart failure in 2013 have normal ejection fraction. And indeed, ST2 concentrations are equally useful for prognostication in patients with reduced EF and preserved ejection fraction. Interestingly, in multivariate models, in examining patients with preserved EF and low EF, ST2 remains a significant predictor of prognosis in normal EF and reduced EF. NT-proBNP is only a predictor of outcomes in patients with reduced ejection fraction. So it's interesting in this study that ST2 actually overwhelmed the prognostic information provided by NT-proBNP in those patients with preserved ejection fraction. Something that's also been seen with galectin-3, where a preserved ejection fraction, one may find additive or incremental prognostic benefit from using a biomarker that reflects fibrosis or hypertrophy. Another special subgroup of patients in heart failure are those with very advanced heart failure. Again, many biomarkers in those patients with the most advanced stages of heart failure become less prognostically meaningful because everything is so abnormal in these patients. Their natriuretic peptides are very elevated, their renal function markers are abnormal, etc. But even in the most advanced heart failure patients, these are patients waiting for heart transplantation, an ST2 value at the time of ICU admission, and Professor Di Sommo, you see the concentrations are very similar to what you notice in your very sick acute heart failure patients, identifies risk out to 90 days for mortality, transplantation, or need for left ventricular assist device placement. No other biomarker in this analysis, including troponin or NT-proBNP, remained in the model. So what about other biomarkers in heart failure? As I mentioned, there are many that have been examined. And in acute heart failure, we've had the luxury in the PRIDE study of having a large amount of sample with which we can examine a large number of biomarkers. This is just one slide showing updates for all of the area under the ROC curves for 1 year mortality. ST2 has the highest area under the curve at 0.8, followed closely by proadrenomegaline, the natriuretic peptides, and galectin-3. The rest start tapering off pretty rapidly, but you can see that at least relative to other biomarkers, there's considerable evidence that ST2 is a very strong predictor of mortality. In subsequent analyses, most recently from the GREAT network, we have data now published in the International Journal of Cardiology in several thousand patients examining a broad range of different biomarkers in the acute setting. These are data looking at the 30-day risk relative to the amount of reclassification each biomarker brings to a base clinical model for mortality. So for 30-day risk, pro-ADM is at the top of the pile, but very closely and very much overlapped with soluble ST2. And as has been seen in multiple studies, out to a year, pro-ADM loses its prognostic strength, whereas ST2 remains at the top, in particular reclassifying a substantial number of patients in terms of the risk. So ST2, again, appears to be very powerfully prognostic, and what's very interesting, as we've argued, and as we said in the clinical chemistry editorial, it would be important to find biomarkers that provide complementary information. As we say in English, orthogonal information. They do not tell us the same thing, the same information when we measure, say, NT-proBNP and ST2 at the same time. And indeed, if you measure ST2 and NT-proBNP, we see actually an additive set of information where patients with both biomarkers elevated have the worst prognosis. With one or the other biomarker elevated, there's an intermediate prognosis, and if both are low, we see a very favorable prognosis. I'll draw your attention to the yellow line. The yellow line are patients with a low NT-proBNP but an elevated ST2, illustrating how ST2 can reclassify risk beyond a single biomarker like NT-proBNP. If we look at other markers, Domingo Pascual in the audience, and who's done a lot of work in this area, demonstrated that the additive value of ST2 together with other conventionally available biomarkers, including NT-proBNP and highly sensitive troponin, substantially reclassified risk, such that patients could be divided into very low risk for mortality, intermediate risk, and very high risk. And I think this is very useful from a clinical decision-making perspective, particularly in the most advanced heart failure patients where we are contemplating the timing of ventricular support and possible heart transplantation, for example. Now, what about serial measurement? I've shown you mainly data based on one single measurement at the time of presentation. Does more than one measurement of ST2 add anything? And I won't go through data regarding analytical statistics like biological variation, et cetera, the amount of change needed to interpret a difference in the value. But ST2 has a very low index of variability. And what this means is that when a biomarker has a low index of variability, it indicates that the information, prognostically speaking, that the marker is telling us can be enhanced by measuring it serially. So serial measurements with ST2 indeed identify patients in acute heart failure who have a high risk for mortality versus those patients who are likely to survive. This looks very similar to a natriuretic peptide, does it not? And indeed, there are two studies from the GREAT network, one from Basel, Switzerland, as well as one from Murcia in Spain. Again, the group of Domingo Pascual and Sergio Manzano Fernandez on the right. And these are data from Christian Muller showing that in patients from presentation to, say, in this case, day 2, in this case, day 4, those patients likely to die had a higher value which fell less than those patients that were likely to survive. So serial measurements of ST2 add considerably to the baseline value alone. And this is important because we've now shown data, these papers are in press at Circulation Heart Failure, that patients with an elevated ST2 value treated with increasing doses of beta blockers as well as mineralocorticoid antagonists and angiotensin receptor blockade and ACE inhibitors can show a substantial reduction in ST2 values following initiation of therapy. Additionally, an elevated ST2 value treated with lower dose beta blockers associated with a very high risk for mortality and heart failure hospitalization versus those patients with an elevated ST2 titrated to a higher dose where we see a significant reduction in risk. And you can again appreciate the difference in Kaplan-Meier curves. So one sees an interaction between, as I said, beta blockers. We also see interactions in terms of mineralocorticoid receptor antagonists. Importantly, these are patients with acute myocardial infarction. These are not patients with acutely decompensated heart failure. However, concentrations of ST2 in acute myocardial infarction identify the risk for development of heart failure. In this study, which was already mentioned by Weir and colleagues from John McMurray's group, concentrations of ST2 that were elevated in red and in yellow identified benefit from treatment with a mineralocorticoid receptor blocker, a Clarinone. In those patients treated with placebo after myocardial infarction, there was significant ventricular remodeling, progression to a heart failure phenotype. Treatment with the Clarinone in these patients blocked this progression to heart failure. Whereas those patients with a low ST2, there was very little difference whether the patient was treated with placebo or with a mineralocorticoid blocker. So because of all of these different data that have shown benefit of ST2 across a broad range of acutely presenting patients, the most recent 2013 American College of Cardiology, American Heart Association Clinical Practice Guidelines for Heart Failure have actually given an indication for ST2, as well as other markers like highly sensitive troponin and galectin for additive risk stratification beyond the natriuretic peptides with the class 2 level of evidence A for acute heart failure recommendation. And this is important because as we start increasing the use of these biomarkers, it's going to be necessary to understand how to interpret them as well as how to best respond to the information that they provide us. And indeed, the methods for measurement of ST2 are in rapid evolution. There's now a point-of-care method for measuring ST2 just about available that's based on a whole blood point-of-care lateral flow method that gives a qualitative result relative to the threshold of 35 nanograms per milliliter. And a quantitative point-of-care method is soon to come. So having a point-of-care ability to measure ST2 will enhance the ability to use the test in the emergency department setting. We measure it in the chronic setting because we send the sample to the lab for ELISA measurement. But again, having the ability to measure it at the point of care would be of great benefit. So in conclusions, ladies and gentlemen, Madam Chairman, Professor DiSomma, ST2 is a circulating biomarker of cardiovascular fibrosis and hypertrophy with powerful links to a wide range of short and longer term adverse outcomes in patients with heart failure. It is equally prognostic in heart failure with reduced and preserved EF, and remains even prognostic in those patients with very advanced heart failure. I did not talk about our work looking at ST2 to identify the likelihood of heart failure onset in normal patients or in those with coronary disease. I believe Dr. Daniels will speak on that. In most studies, ST2 is among the strongest prognostic measures, often the strongest, and survives adjustment for multivariate considerations such as renal function, natriuretic peptides, troponins, and therefore adds substantial prognostic information to these other biomarkers. Lastly, in patients with acutely decompensated heart failure, it is possible to utilize ST2 in a serial monitoring strategy, and based on the observation that therapeutic interventions have an effect on both ST2 concentrations and the risk that it predicts, the use of ST2 to guide therapy appears very promising. So we come back to this slide from the work that Roland von Kimenod and I did, just making the point that ST2 very much next to the natriuretic peptides fits many of these different recommended points. And as we begin to develop a strategy regarding the treatment of patients based on ST2 concentrations, I see a very bright future for this interesting biomarker. And with that, I will stop with a photograph of Boston. Thank you very much.
Thank you very much for this very interesting update on the clinical use and utility of ST2, and also compared to the other biomarkers. My question is a very basic question. Since also BNP, for instance, is released in response to interleukin IL-18, if I'm not. Your idea is that also the interleukin profiles, cytokine profiles, change during heart failure with the kinetics, which can be followed.
It's very interesting that in other cases of inflammatory markers, we don't often see such a rapid change in the course of treatment the way we do with ST2. ST2 has a sequence that resembles an interleukin receptor, and interleukin 33 is an interleukin family member based on its sequence more than anything else. They are very different than many other interleukin family members, however, and it is very possible that in evolution they started from a common family of interleukins, but over time they evolved to have a very different role than the way we think of interleukins in the body. There is no question that interleukin 33 and ST2 have effects on immune function, on T cell in particular, inducing tolerance. However, the role of IL-33 and ST2 in the heart appears to be very different and is more focused on fibrosis and hypertrophy than anything else.
Other question? Yes.
In your experience, do ST2 levels influencing the length of stay of your patient, and is there any impact on the rehospitalization risk?
So it's a very important question, both in terms of identifying a patient ready for discharge, as well as making decisions about improving the short-term prognosis. We have not specifically looked at this question yet. You do know, I'm sure, in the United States, there has become a very specific focus on improving 30-day rehospitalization rates. And so it is definitely something worthwhile to examine, particularly given the very powerful prognostic implications if the ST2 value has not fallen by the end of hospitalization. But I do not yet have an answer for you.
Other questions?
Do you suggest a different threshold values for acute composite heart failure and also chronic?
Can you repeat?
Should we look at different threshold value for those with acute compared to chronic, and especially those with the adverse advanced heart failure looks quite much higher than?
It's a very, very important question. In normal populations, the 97th, 98th percentile is 35 nanograms per milliliter, which is a very reliable cutoff, and the one that we've really focused on across all of our studies. But just like with natriuretic peptides, as patients are in worsening heart failure, we see higher values. And so in studies of acutely decompensated heart failure, from Bionics, for example, from other trials, the optimal threshold for predicting death is, as you saw, up around 100. It has not yet been optimized yet. And what I tell my students when I teach about this is that this is a continuous variable. Higher values are worse, lower values are better. There are some patients with advanced heart failure that have much lower values. And so while you are right that we usually expect higher values, not everyone has those numbers. And so I prefer to think of it in a continuous manner, and I obviously stay with 35, but recognize that many patients with very advanced failure have much higher values. When you see these people back in the office, however, I did not speak on chronic heart failure. When you see them back in the office, it falls back down to the 30-40 range. And so I think that the single first cutoff is very useful, but again, one needs to recognize that you see a wide range of values.
Do you still suggest that it's better to follow the patient with a multi-marker follow-up, either for the diagnosis or the risk stratification of the patient?
Yeah. So this is a very important question because the world is very cost conscious. And so is it necessary to use both markers? I would say that with 15 years of natriuretic peptide experience, it is difficult to immediately stop measuring natriuretic peptides and only measure ST2. However, I would say that it is very difficult to envision not having the measurement of ST2 now that I've been measuring it in my patients with heart failure. So I do both together. I measure ST2 and NT-proBNP, for example, at every office visit. And very frequently what I find in these patients is that the NT-proBNP, because we are very focused on guided heart failure therapy to lower the NT-proBNP value, I find that the NT-proBNP concentration is frequently low, and sometimes the ST2 value is still high, allowing for additive risk stratification and making some therapeutic decision making. It's important though, because as we start making decisions about choosing one marker or another, it will be necessary to recognize that ST2 does provide very powerful information. And I think as we start learning more about its value for guiding therapy, I could envision that it might replace other markers for therapy guidance if we find therapies that actually lower risk associated with it. I showed you some data that are coming out in circ heart failure, for example, that suggests that we might be able to.
Other question?
Just wanted to have an idea in what terms the reducing of ST2 can give us an answer. Is the heart failure stabilized, or is our treatment successful, or we need to do something more?
It's a good question. The resampling time. In acute heart failure, it behaves very much like a natriuretic peptide. So generally by day 3 or 4, the patient is hemodynamically recompensated, and natriuretic peptides tend to fall at that point. We see the same thing with ST2. So it has, in some ways, a lot of common behaviors with BNP and NT-proBNP, where the change that occurs in acutely decompensated patients is within a few days. In chronic heart failure, we tend to resample it at 2-week intervals, where we see a substantial change within a 2-week period. But I don't know if we measured it every day if we'd see the same rapid fall in chronic heart failure. I suspect probably not. In chronic heart failure, where things are much more stable, the changes are slower for natriuretic peptides as well as ST2, in my opinion.
Okay, thank you again.